So good afternoon, ladies and gentlemen. Thanks to join today's online seminar. I'm Nina, the Director of Overseas Medical Mission Center of Zhanghua Christian Hospital. So I'm also the moderator of today's session. But first of all, I would like to thank all of our participants from different countries and sectors. Special thanks to our three speakers. In recent years, I think the AI and artificial intelligence has been developed as a new tool in helping diagnosis. AI can increase productivity, accuracy, and efficiency to provide a better healthcare system to patients. On July 17th, if you join our another online AI seminar, at that time that we have shared that the AI was applied to diagnosis and diabetic retinopathy of patients. And today we want to share another aspect of the AI application on digital pathologies. So today we invite the data scientist from Zhanghua Christian Hospital, doctor from National Taiwan University Hospital, and the CEO from aetherAI company to share the AI-powered diagnostic support system on assisting pathology and digitalizations. So I hope through today's talk, you can get the list of the AI development and on the clinical practice. So we have three speakers to join us today. So let me remind each of the speakers, you have 15 minutes to present your topic. And Q&A is after all speakers finish their talks. So all speakers, please control your time. For our attendance, if you have questions, please use the chat box to leave the questions. I will collect the questions for speakers to respond after all of the presentations. So we are going to start the presentation. The first speaker is Dr. Chen. And Dr. Chen is the data scientist of AI Development Center of Zhanghua Christian Hospital. And she is going to share AI-based computer-aided system for histopathology image. Dr. Chen, the floor is yours.
Okay, good afternoon. My name is Colleen, and I'm the data scientist of Artificial Intelligence Development Center. Thanks all for being this talk. I'm very glad to have this opportunity to share about AI technology using histopathology imagery with you. This is my outline. I have divided into 4 parts. I'm going to start with the introduction of pathology and computer-aided diagnosis system. Next, I will talk about benefit of AI care system in digital pathology. Then sharing 2 AI applications in different imagery types, and finally summarize 2 list application and future work. I think everybody has experience going to medical center, taking X-ray or health check. Whether they are seeing internal medicine, surgical, or oncology, doctors often tell us we need to do some more professional examination and even take a specimen by clinician on the spot. These specimens are usually sent to the pathology department immediately. Whether the pathology will prefer an examination, and clinician will inform the patient and family member of the reported result a few days later, and then discuss the treatment method and the procedure. From this, we can know the pathology is a result of specializing in cases, pathogenesis, prediction, actual progression, and effect of disease. Pathology has long been regarded as an important link between basic and clinical medicine. Now let me talk about digital pathology. In fact, it first converts traditional tissue slides into digital slides, but it can be set up and stored convenient for pathological review and retrospective investigation. It's conceivable that in this way, internal medicine, surgical, radiology, oncology, and physicians can at the same time discuss in different spatial environments and jointly provide patients with accurate diagnosis and treatment method. Of course, the patient's waiting time for reports is greatly shortened. But the photo and huge information of patient increases the stress of pathologists and decreases the efficiency. To reduce the negative impact and challenge, computer-aided diagnosis and proposed to handle the huge image data. CAD systems utilize modern imaging process techniques and AI whether diagnosis, abnormal region detection, or segmentation. Computer technology implement the pathologist experience in biomedical characteristics and automatically reduce routine tasks. So, the convergence of advanced imaging and enabling technology like AI, machine learning, deep learning, natural language programming is empowering the healthcare industry to unlock medical breakthroughs at an unprecedented pace. Combining AI and CAD system has 4 benefits for doctors: more personal treatment for patients, optimize workflow, improve work efficiency, and more time to address abnormal cases. So AI is here to assess pathologists and make them better in what they do. With the AI, pathologists can dedicate their time to more meaningful tasks and be more efficient in their jobs. Today, I'd like to share my 2 AI application researches in different digital pathology images. Topic 1 is malignant region segmentation of prostate cancer. The other one is image registration of several different protein sections. That is the purpose of cell-level alignment that extract each protein to construct protein's interaction spectrum. Okay, let's move on. Topic 1. For pathologists, reading prostatomy specimen image to determine extent of cancer of Morgan status is time-consuming and cumbersome task. So CAD system that can draw the outline of cancer regions will reduce the workload of pathologists. However, there are 2 challenges for this CAD development. The first challenge is gigabyte size, and the second challenge is color deviation problem. Because using common computing hardware cannot run gigabyte size, and color deviation is leading to mistake in tissue segmentation and classification. To solve these challenges, for medical image detection and classification, let quality of the tissue texture and the surrounding tissue are critical factors affecting the CAD system performance. So we propose an AI CAD system that can support color normalization to solve the color deviation problem at first. Besides, it can extract more precise texture features for classification. Next, we segment the different tissue regions using a tissue segmentation algorithm. Then we applied image resetting operation on segmentation region to extract the tissue features. Finally, the result region from the tissue segmentation and image operation will feed into the CAD system to determine if the tissue is malignant or benign. Let me show my result in this topic. In our result, compared with other similar methods, the proposed CAT system has the highest performance. In this study, a color normalization algorithm was suggested and applied to proposed classification model. This shows the AI algorithm as a basic classification model for the proposed model. Enhance the classification performance, which is great interest. In this figure, the result indicate that the proposed segmentation method can outstanding identify histological structures. Different aggressive lesion regions are well segmentation by using the proposed tissue segmentation method. Okay, let's move on to topic 2. Accurate and precise alignment of histopathology tissue section is a key step for the interpretation of proteome topology and cell level reconstruction of disease tissue. However, the realization of an automatic and robust method of aligning non-globally stained immunohistochemical section is still challenging, such as most histopathology slides are maturely mined, thereby introducing various distortion to the tissue section, such as cut, folds, tearing, and local tissue stretch or compression. In this study, we aim to assess the possibility of automatic image registration on aligning serial whole slice image section. In this research, we use 5 different proteins to implement our proposed method. We proposed AI graph-based registration algorithm that improve the unsupervised content non-rigid registration method to address this issue. Our proposed algorithm contains the advantage of both rigid and non-rigid registration method. Initial registration of high-resolution slides, where a rigid method perceives the main morphology information. Following nonlinear low-resolution slides registration information, and the proposed graphic-based registration provides high-resolution imagery to cell-level alignment. This is our result. We proved that by hot-stop distance, our method was able to improve the overall alignment accuracy in different protein section images. Table 2 shows the result oriented by using different registration stages for each slide pair. The results indicate that proposed method can outstanding improve tissue structure registration. The overall performance improved about 52% and 29% for the average and standard deviation value with hot-stop distance, respectively. The particle quality performance becomes also obvious by the registration results with evaluated visualization. Fortunately, in real human biology, cells with similar of related function usually work together as micron units, such as in micron vessel, which has a size greater than 50 micron. With a micron structure alignment, most functional topology postomic can be correctly interpreted. Some other modern techniques, such as C2 mass spectrometer could detect multi-type protein status on single slice, give an even more accurate evaluation of protein interaction. However, these methods are usually expensive, labor-intensive, and high techniques demanding, making them unlikely to be screening tool. Hence, these results display this. The proposed method provides feasibility and a robust image registration method for serial section slice. Advanced screening studies of proteome topology and further cell level reconstruction of this disease tissue. Let me summarize briefly that we have looked at. Whole slice pathology imaging is an essential tool in digital pathology. Nowadays, more and more computer tools are applied in modern pathology modalities. Due to the diagnosis and analysis is a complicated task in whole slice imaging. Hence reading whole slice image has to depend on expertise of highly trained pathologists to provide standard diagnosis procedure. The development of the CAS system will be effective and useful in assessing pathologists in automatic diagnosis routine tasks. One leader summarized digital pathology future vision as the future of AI in digital pathology is not just about increasing the diagnosis accuracy of the pathologist. The future AI is a refined precision diagnosis tool for clinicians in service of patients. It should be the focus of digital pathology. We have a way to go in order to ensure organization and prepare to utilize AI-based digital pathology in their daily work stream by ensuring appropriate use case leverage AI-based technologies, establishing FDA boundary, making the technology accessible and enabling to broader community. There is bright future and opportunity to improve outcome for all. That brings me to the end of my presentation. Thanks for your attention.
Thank you, Dr. Chen. So the second speaker is Dr. Chiu. He is the attending physician of Division of Gastroenterology, National Taiwan University Hospital. Dr. Chiu will share it's the prime time to implement artificial intelligence in colonoscopy practice and colorectal cancer screening. Dr. Chiu, the floor is yours, please.
Okay, thank you very much for the very kind introduction. Can you hear my voice clearly?
Yeah, very good.
Okay, thank you. So it's my great pleasure to be here and make this presentation. I'm Dr. Chiu from National Taiwan University Hospital. And first of all, I would like to thank to the organizing committee of the Zhanghua Christian Hospital for the kind invitation to this wonderful workshop. So today I would like to talk about the application of AI in clinical medicine using colonoscopy, one of the most commonly performed clinical procedure as an example. So this slide shows the 10-year result of the Taiwan colorectal cancer screening program. And it is evident that colorectal cancer screening could successfully and significantly reduce the risk of colorectal cancer deaths. The overall effectiveness in reducing colorectal cancer mortality was 35%, and advanced stage colorectal cancer was 29%, according to the results from our program. The colonoscopy played a crucial role in the logistics of colorectal cancer screening, either serve as the primary screening modality or the diagnostic exam after a positive stool test. Its ultimate goal is to reduce colorectal cancer deaths by early detection of colorectal cancer and reduce its incidence by detecting a removal of precancerous lesion. The effectiveness of colonoscopy is, however, dependent on its quality. There are three important domains of colonoscopy quality, including technical domain, patient safety, and the patient experience domain. Regarding technical domain, many indicators such as bowel cleansing level, completeness of colonoscopy, or with short time, all surrogate to adenoma detection rate. Therefore, it is one of the most important quality indicator of colonoscopy. According to previous study from Poland, the ability of endoscopy to detect adenoma or polyp during colonoscopy was closely associated with the risk of developing colorectal cancer after colonoscopy, which was theoretically assumed to be very low. One study from the US demonstrated that every 1% increment of ADR was associated with 3% reduced risk of post-colonoscopy colorectal cancer, showing the clinical significance of ADR. It was reported that missed lesions are likely the most important attributable factor of post-colonoscopy colorectal cancer, which account for nearly 60% of PCCRC, followed by newly developed lesion and the incomplete resection of the detected neoplasm. And thanks to the development of AI technologies, AI-assisted colonoscopy was developed a few years ago, and could help the doctor to identify polyps during the colonoscopy. Earlier this year, US FDA approved AI-assisted colonoscopy platform, the GI Genius by the Medtronic company, for the first time. So we can see many advertisements of the clinic mentioning that they have implemented AI-assisted colonoscopy in their unit, which attract the attention of the public and bring the colonoscopy practice into a new era. So what are the current evidences on using AI-assisted colonoscopy in detecting colorectal polyp? A recent meta-analysis included 6 randomized controlled trials, with 5 from China and the remaining 1 from Italy. All these studies directly compared the ability of detecting adenoma by AI-assisted colonoscopy and conventional colonoscopy. Of them, studies from China were conducted in screening or surveillance colonoscopy setting, whereas the study from Italy was conducted within the fecal immunochemical test-based screening program. Therefore, the ADR in this Italian study was much higher than the others. The ADR was significantly higher in AI-assisted group, with 76% increased likelihood of detecting neoplastic lesion. If all polyps, including non-neoplastic one, were taken into account, AI-assisted colonoscopy was able to detect more polyps, with 90% higher likelihood of detecting polyps. Proximal colon is where post-colonoscopy colorectal cancer are more likely to occur, and this meta-analysis revealed that ADR at proximal colon was also significantly higher in the AI-assisted group. As you can see here, using AI-assisted colonoscopy could increase the likelihood of detecting proximal colon adenoma by 81% and the distal colon adenoma by 96%, which is remarkable. The time spent on inspecting colonic mucosa at withdrawal phase of colonoscopy was slightly longer in the AI-assisted group, and no significant difference in those procedures with no polyp being detected. That being said, that using AI-assisted colonoscopy take a bit longer time, but seem likely a worthwhile trade-off with the gain of more lesions being detected. In another meta-analysis published in GI Endoscopy, it was revealed that the detection of both polypoid and non-polypoid adenoma were increased by using AI-assisted colonoscopy. And it is notable, it is well known that non-polypoid lesions carry higher risk of advanced histology, but are more likely to be overlooked due to its subtle morphology and were speculated to be more responsible for post-colonoscopy colorectal cancer. It was also demonstrated that C-cell selected lesion, which is morphologically very subtle but very likely to progress into invasive cancer once dysplasia develops, are more likely to be detected by using AI-assisted colonoscopy. However, in another meta-analysis, it was demonstrated that the detection rate of advanced adenoma, which is a clinically more relevant proxy to invasive cancer, did not increase in the AI-assisted group. In this analysis, we can see that although the detection for any adenoma was significantly higher in the AI-assisted colonoscopy group, it was mainly attributable to the increased detection of small adenoma, and there was no significant gain in detecting advanced adenoma, which carry a much higher risk of malignant change. When we look at the total number of adenoma per colonoscopy, we can find that the additional adenoma being detected by AI were mostly diminutive in size. Accordingly, a large-scale study enrolling much larger population is warranted to demonstrate the efficacy in increasing the detection of advanced adenoma or large non-polypoid lesion. Aether developed its AI-assisted colonoscopy platform using the large number of archived colonoscopy still images and the videos in Kansas General Hospital and the National Taiwan University Hospital. Its major advantage is that it is not dedicated for specific endoscopy system, but is an add-on system that is compatible to most of the currently available endoscopy systems in the market by different companies. So this slide, you can see how our AI system detects the lesion, and the frame is on our monitor. And this is the video showing that aetherAI-assisted colonoscopy system successfully detected C-cell selected adenoma, which could only be detected by identifying the mucus covering on its surface. Such kind of lesion may develop rapidly into invasive cancer once dysplasia appears. And overlooking such kind of lesion is very common and may lead to post-colonoscopy colorectal cancer. The AI system beautifully identify and frame this lesion, as you can see here. There are, however, many challenges lying in front of us and they need to be elaborated. I have to emphasize that colonoscopy is important, but not equivalent to the entire colorectal cancer screening, and there are many aspects that AI could play some important role in this ecosystem. What kind of lesions are really clinically relevant in terms of preventing post-colonoscopy colorectal cancers? A recent study from Japan, the Japan Polyp study, revealed that flat nail problem, especially the retrospading tumor non-granular type, is of utmost importance, and overlooking such kind of lesion may significantly increase the risk of post-colonoscopy colorectal cancers. In this video, you may see that such kind of flat lesion, retrospading tumor non-granular type, was identified the AI-assisted colonoscopy under both white light endoscopy and the narrowband imaging mode. It is intriguing to know which level of endoscopy that AI-assisted colonoscopy is most helpful. According to a recent study from Hong Kong, it was revealed that AI-assisted colonoscopy significantly increased the ADR of less experienced endoscopists. In addition to ADR, cecal intubation rate is also associated with the risk of post-colonoscopy colorectal cancer. As you can see here, according to the results from Taiwan Colorectal Cancer Screening Program, it was revealed that those with incomplete colonoscopy was associated with 76% higher risk of post-colonoscopy colorectal cancer, even after adjusting for ADR. Such a finding may be caused by incomplete inspection of the chronic mucosa and affect the total number of adenoma being detected, which could not be entirely explained by ADR. In the US, benchmark thresholds are set for several key quality indicators for colonoscopy, including ADR, cecal intubation rate, scope with withdrawal time, and the adequacy of bulk preparation, and are regularly audited. Another important issue is whether the endoscopy are happy to use AI-assisted colonoscopy. Some doctors may think that using AI-assisted colonoscopy may prolong the procedure time, which may affect the number of procedures that could be performed and affect the incentive as well. If AI-assisted colonoscopy is able to differentiate neoplastic from non-neoplastic lesion and advise not to resect the latter, then this may again reduce the incentive of the endoscopist. Effectiveness refers to doing the right thing or achieving desired result. Efficiency refers to doing the thing in an efficient manner or in the right way. These two key aspects are also applicable to the colonoscopy practice. Whether colonoscopy could detect as many polyps and accurately diagnose their nature are associated with its effectiveness in preventing colorectal cancer, avoiding unnecessary complications, saving money, improving the efficiency of the workflow, and improving patient experience, which is closely associated with screening uptake. As such, it is the right time to think whether state-of-the-art artificial intelligence technology could play more role in those aspects other than ADR. There are many aspects in clinical medicine that modern technology could contribute. Chatbots and telemedicine could help to stimulate screening uptake. Wearable devices could help to coach lifestyle and monitor physical activity and vital signs. And the natural language processing technology could help to manage text or voice data or sort and analyze non-structural electromedical records. In colorectal cancer screening, in addition to colonoscopy itself, there are several labor-intensive tasks such as generating endoscopy report, managing large number of pathological slides, and the calculation of colonoscopy key quality indicators. Recent study also revealed that deep learning technology can predict microsatellite instability, which could guide treatment and is associated with prognosis of colorectal cancer, just using the conventional HE-STEM pathological sliders. The state-of-the-art deep learning technology are now able to extract and provide more accurate prognostic information from the tissue morphology of colorectal cancer than an experienced pathologist or the current used TNM staging system. Therefore, it is the right timing to embrace AI technology to facilitate colorectal cancer screening. In addition to enhancing the performance of colonoscopy, AI could also help to diagnose pathological slides in a high throughput manner, automatically generate endoscopy report, identify potential target population based on individual risk profile, and notify them to go for screening. The automatically generated colonoscopy quality metrics can further apply to the so-called pay-for-performance healthcare system. All these items may collectively contribute to both the effectiveness and the efficiency of colorectal cancer screening. In summary, ladies and gentlemen, it is about time to embrace AI-assisted colonoscopy in our practice. But if you rethink the ultimate goal of colonoscopy or colorectal cancer screening, there are still many aspects that AI could play important role or even become the game changer, which need further exploration and elaboration. Our future challenges include how to implement it into the clinical workflow, how to enhance the willingness of the doctor to use it in their practice, or how to evaluate its efficacy using the hard outcomes such as colorectal cancer incidence and the colorectal cancer mortality. Thank you very much for your very kind attention.
Thank you very much, Dr. Chiu, very great presentation. So our last speaker is Dr. Ye, and he is the co-founder and CEO of aetherAI company. Dr. Ye, we are talking advancing medical imaging with artificial intelligence. Dr. Ye, the floor is yours, please.
Thank you for your introduction, Dr. Gao. And it's my great pleasure to be here to talk to you about some of the progress we have been making at aetherAI, especially regarding Pathology-AI. I am Joe, co-founder and CEO of aetherAI. We are a medical imaging company based in Taiwan, and we were founded in October 2015. The company was dedicated to developing digital pathology workflow and AI diagnostic support systems. Currently, we have over 65 employees, and through collaboration with medical centers in Taiwan and US, we have over 15 ongoing medical imaging AI projects in our pipeline. First, I would like to briefly introduce the concept of AI. AI is a very broad field, and it has been developing since 1956. And today, we will be focusing on a very small subset of the AI, which is deep learning. It is actually the driving force behind this current wave of AI revolution. How is AI different from image processing, or say deep learning different from image processing? In a traditional image processing workflow, for example, if we wish to differentiate between the images of a lymphocyte and a segmented neutrophil, we might begin with an expert observation, and we might conclude that the nucleus to cytoplasm ratio is very different between the two cell categories. We then begin with a cell contour segmentation to derive the cell area, and then followed by a nuclear segmentation algorithm so we can derive the nuclear area. And then from these, we can calculate ANC ratio and then easily set a threshold for the classification of the two images. We call this a knowledge-driven approach because it begins with expert observation, and we use the expert knowledge to design an algorithm for image processing. Deep learning is operating in a very different manner. So instead of asking experts for their opinion, we only ask experts to perform annotation on the images. So finally, we feed deep neural network of thousands of images of either lymphocyte or segmented neutrophils and let the neural network to learn on its own what important features are for the cell classification task. We call this data-driven approach. In the past decade, it has been proven many times that deep learning approach is superior to traditional image processing method in terms of image recognition performance. And that is why we see a lot of application of AI in medical imaging booming in recent years. Then I'm going to follow on and provide you with some examples of application of pathology AI that we are developing in the company. First, I would like to briefly introduce some of the pathology's history. The foundation of modern pathology was established in the latter half of 19th century by Dr. Rudolf Virchow. He's called the father of modern pathology. And the most commonly used formalin-fixed paraffin-embedded tissue section method, also called the FFPE method, was introduced in 1869. And of course, you need some staining to provide contrast in the tissue. And the most popular staining method, H&E method, was introduced in 1876. And finally, of course, you need a microscope. And the common microscope structure was invented in the 1620s. Why do I put these numbers of years here? It is because these methods have been in place in the past 150 years and have not been changed. So in a sense, pathology is a very traditional discipline. And I think that actually leads to some problems that pathologists faced in their daily workflow. So for example, early and small lesions or pathogens could be easily missed. For example, mycobacteria, the pathogen for TB, is a very tiny rod-like object and is very easily missed if you're looking at a very large tissue specimen. Similarly, isolated tumor cells and micrometastases are easily missed in lymph node sections. Another challenge that pathologists have been faced with is for IHC quantification report. So for example, on the right-hand side, you see an image of PD-L1 stained tissue. Pathologists have to report the percentage of cells stained positive for PD-L1. And trust me, no pathologist counting cells one by one. Instead, they rely on a very rough visual estimation of the PD-L1 positive percentage. So these can lead to inefficient and potentially inaccurate diagnosis for pathological reading. Is digital pathology the solution? It is hardly the solution because now with digital pathology, you still have to deal with the problems of visual estimation. But we believe that the combination of digital pathology and AI is the future. So now I'm going to move on to some real examples that we have been developing at aetherAI. The first example is differential counting of bone marrow smear. Bone marrow smear is a procedure patients have to undergo when they're suspected of having hematologic disease. Medical technicians or doctors have to perform differential counting of roughly 500 bone marrow cells. This is a very cumbersome and labor-intensive process, and highly trained experts are in shortage. In the past, traditional image processing methods cannot deal with this challenge of bone marrow smear differential counting because the images are too complex. But we believe that deep neural network can do the task well. So in collaboration with National Taiwan University Hospital and 3 other institutions, we have collected in the past 3 years close to 600 bone marrow smear slides, and we took new images at 1,000-fold magnification. The critical challenge of this project is to provide annotation. And so far, we have annotated over 1 million cells. And in this project, we use a MaskR CNN-based cell detection and classification deep neural network model for the image recognition task. Here is an example of a bone marrow smear image. As you can see, cells are often crowded, and there are many fine features in the cytoplasm that are making it very difficult for traditional image processing methods to deal with in terms of the cell classification task. To train deep neural network, we have to provide annotation. And as I said, this is the most critical challenge of this project. Here is an example of annotated image. As you can see, we have to provide contour annotation as well as cell category annotation. And this is a very time-consuming process, but we think it will be well worth it. Currently, we have annotated over 1 million cells. And of course, we want to make sure that the AI is performing well in different disease categories. So we took extreme care in carefully selecting different cases of hematologic diseases and try to make sure that our AI is performing at similar level in different disease categories. Here is a summary of the model development dataset. So we have used a training set of close to 600,000 cells. In this project, we have a special design in terms of the test set. So there are 46,000 cells in the test set, which are triply annotated. So when we look at the testing set, we found something rather interesting. So if we look at the consensus rate, we found that only 26,000 cells have consensus from all 3 examiners for the testing set annotation. And if we're only counting 2 examiner consensus who have more cells, but still there's a high rate of inconsistency between the annotator. These are actually all very experienced annotators. So this is also one challenging part of performing differential counting in bone marrow smear. In the end, we only use cells that have consensus annotation from all 3 experts to use as the test set. And with this test set, we can see that our AI model is reaching an overall classification accuracy of 94.8% across the 3 major cell categories. This is an example of a new image being analyzed by our AI model, and you can see that AI is doing a perfect job detecting cells and draw contour over cells with different color representing different cell categories. And if you're curious, these are the categories of the cell. Our AI model comes with an AI box attached to a microscope with a high-resolution camera. So with one click, the AI will take over and perform the classification task. In our first phase of product development, we took a human-computer collaboration approach. In the second phase, we now move on to the fully automatic method. And we saw some challenges in this project. The performance of deep neural network is heavily dependent on the training data distribution, and real-world data is too messy. And very often, we cannot be sure what exactly the ground truth is. Here is an example of how diverse the data set could be in the real world. So these are images coming from different hospitals. As you can see, this poses a big challenge for AI model to adapt. And as I said, in the second phase of our model development, we're now moving to a fully automatic system. So I'm going to play a video showing you the fully automatic system. What you're going to see in this image video is that our AI is driving a motorized microscope to first locate the specimen, and then it is going to switch to a 10x objective and look for regions of interest that have appropriate cell densities. So these red boxes are the regions identified by our AI model to have appropriate cell densities for differential counting. If the areas are too dense, the cells will be too crowded, making it difficult for differential counting. If the areas are too loose, then it'll take too long. So finally, our AI is switching to the 100x objective and move to these regions of interest to capture the high resolution image and send these images to the final differential counting AI model. And in the final phase, the human observer can still correct the answers made by AI. And after these results are verified, our system will send out a summary report characterizing the proportion of each cell categories. Using our fully automatic system, completing differential counting for one bone marrow smear will take only 3 minutes, whereas it'll take human beings somewhere between 15 to 30 minutes to finish differential counting for one case. This is the second example, which is training AI to detect nasopharyngeal carcinoma in digital slides. So detection of a small cancer lesion could be difficult and challenging sometimes, especially for the less experienced pathologist. So our goal is to train AI to recognize cancer lesion in nasal biopsy. Through collaboration with Chang'an Memorial Hospital, we use close to 1,000 slides to develop this AI model. And digital slides are of extremely high image resolution, so we have to divide images into patches. So first, we train a patch level model using roughly 10 million patches and divide the patch into 3 categories, either background, benign, or cancer. Our patch level model was able to reach an AURC of 0.99, close to a perfect algorithm. After whole slide images being processed into patches, so each patch will be processed by the model and into one of the 3 categories, probability score. So in a sense, the whole slide image is turned to a small image. And then we use this small image to train a slide level model and reach an AURC of 0.98, a very good performance. This work has been published in Cancers in 2020. On the right-hand side, you can see how AI is helping doctor to perform diagnosis by drawing an overlay of red color over the cancerous area. The AI can be most helpful in challenging cases where the lesions are small. So for example, in this specimen, a very large piece of nasal biopsy contains only 3 small lesions of nasopharyngeal carcinoma, which are highlighted by AI. And this is actually a case missed by the first-year resident because the lesions are too small. Of course, AI can be also very helpful in quantifying the tissue area. And so because AI can do this patch by patch, whereas human beings can only perform a very rough visual estimation. But what we saw in this project is that annotation is a very big burden. So pathologists have to spend over 1 hour per slide when he's trying to teach AI using detailed annotation. So we keep coming back to this process and examine why it is so labor intensive. So it is because we have to go with a patch-based method, and that is because the whole slide images are of extremely high image resolutions. So in aetherAI, we are developing new ways to use entire whole slide images with sign-out diagnosis to let AI train directly on entire whole slide image. And this is a publication came out this year. So we're able to use entire whole slide images undivided with a sign-out diagnosis to train AI directly for image recognition task. Panel A shows the traditional patch-based method where you provide annotation for each image patch. Panel B refers to a weakly supervised method, so-called MIL, without detailed annotation, but use a pre-trained classifier on natural images. Our method, the panel C, is a very straightforward method. We train AI directly on images up to 400 million pixels and train it to recognize cancer. In this table, we can see that our model is performing better than the previous state-of-the-art method, the MIL, and reach an AUC for adenocarcinoma classification of 0.95, roughly 2% better than the previous state-of-the-art method, MIL-RNN. And here you can see that our AI model, although initially being trained only for a classification task, can also perform very excellent lesion localization results seen in panel F. And this is much better performance compared with the panel E, that is result coming from the MIL method. And finally, we use this method to train an AI model to recognize the micrometastasis in colorectal cancer. Typically, this kind of AI is performed or trained using detailed annotated whole slide images, but that is too labor intensive. So using our new approach, we use 3,182 whole slide images with sign-out diagnosis and no detailed annotation to train AI directly. The result was astounding. So using a test set of 1,000 slides, we're able to show that our AI model trained on whole slide images can reach AUC of 0.9967. That is, for the 1,000 testing cases, we only made a mistake in 3 cases. On the right-hand side, you can see one image showing our AI model correctly identifying a micrometastasis in this large slide. So panel D is a zoomed-in image of the panel B. And in terms of micrometastasis, our AI model is reaching still very excellent AUC of 0.9956. So we believe AI model trained in this way can save a lot of annotation time while still helping pathologists making very accurate diagnosis and making this process very efficient. And this is a list of the scientific publication we have been making at aetherAI. This is my talk. Thank you very much.
Thank you very much for Dr. Ye, very great presentation. So now we are open for QA. And I saw a question from our participants. The question is, as there must be some data bias across different institutions. So how aetherAI deal with it to make the model more transferable? Dr. Ye.
We would take a two-pronged approach. So to begin with, in the training data, we try to increase the diversity by collecting data from different institutions. And also we try to augment the image as much as possible. But in the data augmentation phase, we also try to apply the relevant data augmentation method that can cover the diversity in the different institutions. So there's no magic bullet. Essentially, you have to increase the diversity in the training data and increase or say use ample data augmentation technique. It would also be helpful if you can try and look at the other institutions and see what their data are like. Sometimes you can also approach from the other side. So for example, for the bone marrow smear, we also try to standardize the staining process to make it easier for AI to adapt to different institutions.
Thank you. I also have a question. I think that your company deal with many of hospitals try to convince them to install or apply that your system. So what is the most challenges when you're talking with those of hospitals?
I think the biggest challenge, the central question is the return on investment for either digital pathology or AI, because this is a new technology and its value has not been proven widely. So persuading hospital to be early adopter takes a lot of effort. So we usually begin by academic research, showing that AI can truly help with the daily clinical workflow. And by showing these values, we can persuade hospital to invest in these new technologies. And also down the road, we continue our research collaboration and continue to show that AI can be truly helpful. And in recent 2 years, we have been moving on to a different kind of research, trying to characterize the actual economic benefit that AI can bring to the healthcare system. So for example, we're planning a clinical research. We want to prove that with the introduction of AI to endoscopy, we can effectively lower the interval cancer rate by increasing adenoma detection rate. And if we can come up with a hard number, then we can do some math and calculate the value that AI bring, and it'll be easier for us to convince hospitals to adopt these AI augmented system. So there's still some research to be done, but research is always our best strategy to convince hospital to invest in these new technologies.
So do you think in the future, the pathology or the medical imaging physician might be substituted by AI?
No, that will never happen, at least for the future 500 years. On the contrary, I think radiology and pathology will be a very interesting discipline to be practicing in, because in the past, pathologists have no help. They can only rely on their naked eyes to perform quantification, but now they have powerful tools. Let me give you an example. So right now we're using AI to perform nuclear morphometry. So we can actually derive quantitative results for lymphoma cell morphology. So in the past, they have to use very vague terms, for example, monomorphic lymphoma versus pleomorphic lymphoma, but now they can actually give you a number of how irregular the nuclear shapes are, and use that to make more precise prediction of the prognosis. So I think radiology and pathology will be more interesting because these powerful tools can help doctors to perform diagnosis at much higher level than before.
Thank you. So Dr. Chiu, I want to ask, because like the National Taiwan University Hospital, that's the top one in Taiwan. However, it is a government hospital. So do you think any difficulty that when government hospital, you need to convince your like the superintendent to receive like the new technology, because the year budget has been controlled by the government. So do you think any of difficulty?
Yes, so I think the biggest obstacle for government hospital like us is the single payer system of our national health insurance, because whether you use AI tool or not, you get the same reimbursement. So this may affect the willingness of the industry to develop AI tool in clinical medicine, and also the willingness of the hospital to purchase this kind of AI tool, because the amount of reimbursement will be the same no matter you use or not use the AI tool. So I think this is a very practical issues, but we have to find some, incentive or some solution for the win-win strategy for either clinical side and the developer side.
Yeah, thank you very much. Okay.
Yeah, actually, if the AI technology could help pathologists to make a very quick diagnosis of, for example, the colonoscopy resected polyp, nearly 80% or almost 90% are benign one, and most of them are very simple tubular adenoma. So if the machine can do this tedious work on behalf of the pathologist, that can save a large amount of time. And this is another way of saving money. So I think if we can evaluate things like this way, I think maybe hospital will be happy to purchase AI devices. Yeah.
Yes.
Oh, Dr. Chiu, you're speaking my mind. We are working on this kind of AI model in collaboration with NTUH and also Cathay Hospital.
Yeah.
Yes, that's good. Okay, I think the time is almost up, so I will close the session. So thank you very much for our speakers and all of our participants from different countries. Thank you very much to take the time to join us this online seminar. And I'm looking forward to see you, all of you soon in the near future. Thank you very much. Bye.
Thank you. Bye-bye.